you?
Good.
I'm Julie Fernandez.
Hi.
Hi.
Glad to meet you.
Good to meet you. I was just looking at your films, and I spoke to your high school buddy.
Yeah.
And so kind of got a little bit of an idea as to what's going on.
Okay.
But if you just tell me when you first noticed that something
Back
was
in
off.
November, Thanksgiving, was that after?
No, last November around Thanksgiving.
I started losing my appetite. I started losing weight.
Okay.
I lost from 210 down to 180, 175, 178. Mine weight loss last year. My arms got smaller, but I'm everything. I teach line dancing and dancing 3 to 5, 6 times a week. So real active. I got new knees.
Okay.
It's just I can't swallow.
Now, what transpired between November and
well, we went in December. We went down there. They went right past
Borland Grover Clinic and did a
They went right
endoscopy.
past his cancer and went down my stomach and everything looked good.
Okay.
Then they sent me back to.
Sent you to Dr. Dewey because he was having real bad headaches. So they did a CAT scan of the head, then they did an MRI of the brain.
Okay.
And we went to Dr. Dewey, which was the neurologist.
Okay.
And he thought it might be some kind of palsy, possibly, or
Were you
something
having
else.
Any facial palsy or anything?
Just his tongue, paralysis in the tongue.
Oh, you had already paralysis.
Yeah, he was sent to
at that time.
To Herrera.
Okay.
Ruggiero and Herrera, ENT.
When this popped out, he said, "This is carotid artery. You lost a lot of weight and sticking out." So.
Okay. This was in December as well?
No, that was in February.
We lost 30 days, and this thing popped out. He just thought it was my carotid artery because I lost weight.
Sure.
He said, "I feel your heartbeat in that," but that means.
Yeah.
So anyway, he finally, someone could do this in December. Went in my nose, and you can see it.
Okay.
I didn't know you had a hole between my nose and my throat, but
yeah.
I found out.
Well,
and
so
Charlie insisted that I come see you.
Okay.
He's been worried to death about me.
Yeah, he sounded like it. Well, you know, I've looked at your films, and I know that you have already plans to see Dr. Dwellin Simmons to begin radiotherapy. And that correct?
Well, that's who did the PET scan, and we had seen him.
Okay.
But
Charlie insisted we come.
yes.
Okay. Yeah.
Yes.
Yeah. Okay.
And if it's going to be better
And I'm pretty sure that Mr. Simmons and some of his other colleagues had mentioned you.
Okay.
And said that you were the guru of neck and throat, and that we needed to have you look at it. You know.
Well, let me look and see. But I think. I just take a look inside. Okay.
That's just fun for it.
It's tough.
When you get on my nose.
Well, I'm just going to look for now like this for a second.
Well, let's see what he thinks, because you can feel the whole thing.
Can you feel it internally?
Yeah, you have to use sort of fine manual palpation.
Give me the laryngeal one. I'm going to just kind of fill your neck for a second. Any ear pain or anything?
No.
Any pain in your ears?
No.
No.
He's lost
This, my head, I have pain in my head back here.
He tells me if he lays down flat on his head, it's just excruciating pain. But he lays a lot on his side to the left,
It goes away when I'm on the side.
and it's better when he's on the left. And I think that's one of the reasons why they wanted us to see the neurologist and do the MRI of the brain, because they couldn't figure out why the pain would be like it was.
Well, it's called referred pain, meaning some of the nerves that come from up high go down low, and then the tumor invades, or doesn't invade, but pushes on the nerve, and it can cause you pain. Kind of like when you have a heart attack and your arm hurts.
Yes.
You know?
Okay.
It's a bit like that.
Smallest one? This one?
Just breathe through your nose.
still have Goldman's blue default? Do you know? You can get the scope if you want.
No, I can see it.
Looks so mucosal.
All right, so this is the on your scan. Are you a smoker?
No.
A drinker?
HPV positive.
Okay, HPV, perfect. Okay, so the risk factors for this type of cancer is there are a few things. The most common one are drinking and smoking, especially for oral cavity, for the front part, you know, the part that the tongue moves. For the very back part and the tonsils and the throat part, there's another risk which is called HPV, which is human papillomavirus. And in your case, that was positive, which is a good thing. And it's a good thing for a couple of things. It's a good thing. It's also a good thing that you don't smoke, because that means that your response to the treatment is likely to be a lot better. Okay, so now the cancer is in your tongue, in the what we call base of tongue, and it's more on the left side. It's pretty good size on the left side, and extends to what we call, it crosses the midline, and it goes towards the right side, right? Just by feel, I can feel it, right? And also you have a node, a lymph node, what he was referring to as your carotid, that is actually a lymph node that you know, by all evidence.
Sucking the shit in. Like when you get sick, your nose.
Yeah, they swell up. Well, this one, it swells up because the cancer cells travel to that lymph node and, you know, kind of live in there and grow, and it makes it bigger. So you have this cancer there, the base of tongue, that has now had, you know, evidence that it's also in the lymph nodes in the neck, right? At least that one, and maybe more. The treatment for this is because of size, because of location, is what Dr. Simmons had planned, which is radiotherapy. But because of the risks, it also would be what we call chemoradiotherapy. It would also have to add a little bit of chemotherapy agent to it. And I don't know if he discussed with you about using.
He was thinking radiation first, till they seen the PET scan. They was going to decide whether it would be radiation and chemo.
Yeah, I think it would be a good idea to kind of mix the chemo radiation. Okay. Now, it's not something that we do surgery for, because of part of the morbidity or the side effects of the surgery on that location, and also because it responds very well to radiation. And some of the factors that you have would be in the HPV positive, that helps. There's a good chance that the radiotherapy will cure you, right? So the idea is to proceed with what either Dr. Simmons has recommended. I'm going to also present your case, discuss your case today about tumor board, which is a tumor board where everybody meets: surgeons, radiation oncologists, medical oncologists, neuroradiologists, and so on and so on. And we discuss all the patients from that week that have new diagnosis of head and neck cancer. And so we'll talk about you, and then obviously we have radiation centers here and so on. And if you wish to have an opinion from here, or you're being treated by Dr. Simmons, he's a good guy, good doc, and proceed with that. Irrespective, the idea is to get it done, right?
Yes.
From November to now, it's quite a long time,
yes.
And that's why you have such a big tumor now. It's a pretty good size. It's what we call this stage 3 disease, because you have nodes in the neck and the size of it. So we need to get on with it. And if has he made a mask for you and everything? Okay, so if you already simulated and he's made a mask and everything, it may be a good idea to just.
How's the equipment here compared to equipment there?
You know, the thing is I don't know their equipment, but I would imagine it's the same. It's not so much the equipment, it's the individual delivering or making the calculation. And in fact, a lot of the radiation oncologists are pretty touchy about this whole thing because they're like, well, it's not just the machine, it's the person doing the planning that is important, right?
Right.
So what they, Dr. Simmons has treated lots of patients that I have operated on, and they've done well. You also have to think about, you guys live close to Orange Park, right? So
That's a factor, yes.
yeah, it's a factor because it's a Monday, Tuesday, Wednesday, Thursday, Friday treatment for 6 weeks. So that also adds into the whole sort of.
6 weeks is not considered a very long time for cancer.
6 weeks?
It's not considered to be very.
A long treatment period.
No, that's
I hear
that's
people
the
doing 2
normal
years.
treatment. No, that's the normal treatment for cancer, for radiation is 6 weeks. Trust me, you don't want to be.
Well, I know.
You don't want to be treated for 2 years. 6 weeks is a rough treatment, and it's one that it may continue. You may continue to lose some weight, and you may need to have a tube in your stomach.
He said suggested a feeding tube.
Yeah, so those things are all true and likely to occur. Okay, and but what you have to think about is you look like a positive person, you have a good support system, is to go through it, even though you're going to be having periods where it seems like you're going through a valley and things are tough, just to kind of, just remember that it will pass and you just have to push through it. The radiation can cause some soreness in your mouth and all those sort of things, but again, they will dissipate, they will go away over a period of time. Once you finish radiation, about 3 weeks after you complete radiation, I would like to see you back, okay? Because then I would like to make another exam to feel, probably put a camera in your nose and look at your throat and feel, and then about 2 months afterwards, we will do another scan, okay? Usually we won't do another PET scan until about 10 weeks after you finish your radiation, so that we can now look at the response. God willing, we will see nothing, and it'll be all good and done, right? If we see anything that we're worried about, then we can talk about getting it with surgery. But I think the hope is that everything will go away.
There's a lot in there right now.
Yeah, it's a good sized tumor. Yeah.
Now, that's what I wanted to ask. Do you just see one node? Because they said on the PET scan that if it was more than just that in the base of the tongue and the back of the throat, or it's like a little U-shape is what he showed us, the area, that it would light up like a Christmas tree everywhere else that there was. Is there any more?
There's one node there on the left neck that's good size, and then the tongue, it's a pretty good Christmas tree there. I mean, it's just one big blob.
Okay.
Right?
That's why I can't swallow.
Inside the mouth, yeah. But
and that's all you see on the scan.
We'll look at it. I'll look at it again this afternoon, so we'll go through it very, detailed like. And if I see anything else, I'll let you know.
And how often does this board meet?
The board meets once a week.
Okay.
We see.
But
So
they're meeting today. We're lucky today they're meeting.
But what I would do is, when is your next appointment with Dr. Simmons?
We're going to call him after this.
Okay. Do you want me to call them as well? I can call them and I'll tell them that I saw you, and then I recommended that you proceed with the plan as you guys already have.
Okay, and well, here's the thing. He really wants to make sure, equipment-wise. Okay. Now, I was asking this gentleman, I can't remember his name, sorry, doctor.
Yeah, it's okay.
About, we keep hearing about proton and
Proton.
Yeah. Okay.
You know what I'm saying?
There's some, the Proton Institute and the proton therapy. So you have the institute, but that doesn't mean that everything that happens inside is proton. So we still have your conventional treatment, and we have the proton. Right? Mm-hmm. The proton has some good stuff, some benefits in certain cases. Cases where you want to minimize collateral damage to other things that you don't want to have, like prostate, where you don't want to damage important things in life. And it has a certain property that the name is not that important, other than to say that the radiation